A very good morning, everyone. It is heartening to see such a good, robust audience for the Oculoplasty subspecialty. I'm Adit Gupta from Mumbai. I'm going to be moderating this session. Since we are running 10 minutes late already, I will request all the speakers from this session to be on time, and so that we can have fruitful discussions as well. Now, I take the honor to invite on stage Dr. Anita Sethi, who is going to be the chairman for this session. Is Dr. Sethi here?
Adit, her flight is delayed.
Okay.
Yeah.
So then I take the pleasure of inviting Dr. Kasturi Bhattacharjee ma'am on the stage as the co-chairperson and the chairperson till Dr. Sethi arrives. She needs no introduction. Dr. Kasturi Bhattacharjee is the Director of Academics and Medical Director of the Sri Shankaradeva Group of Eye Hospitals. She is also currently the Vice President of AP Soppers. We are delighted to have you here, ma'am. I would also like to invite our international faculty, Dr. Essam El-Toki. Sir, please, can you come on stage? It's a pleasure to have Dr. Essam, who has traveled all the way from Egypt to enlighten us about his preferred practices in oculoplastics. He is currently the professor and heads the Oculoplasty service at the Cairo University Hospitals. He conducts a very famous oculoplastic training course every year called A to Z of oculoplasty surgery in Egypt, and he is going to be speaking to us about baby Botox and techniques of Botox in aesthetic practice. Over to you, Dr. Essam.
Bismillah ar-Rahman ar-Rahim. Thank you so much. Thank you for the invitation. I'm greatly honored. My topic, and I'll try to convey with the timing, is about Botox. And Botox was a milestone in cosmetic surgery. It is the single most commonly performed cosmetic procedure all over the world. And everybody knows that plastic surgery was one thing before Botox and one thing after Botox, okay? And almost everybody who's doing a plastic procedure on any part of the body will always have Botox with it. But also, if you ask any patient or person who used Botox, what is the drawback of Botox? They will have only one answer, that it is not permanent, okay? Everybody wishes to have a permanent, lasting effect of his cosmetic procedure. How can we have a permanent Botox effect? Okay. Can we move the slides, please?
Can we have the slides running?
Okay. The classic Botox injections entails that the patient will come, have a full dose of the Botox, and then after a few months, when the wrinkles starts to come back again, he will come again to get the same dose of Botox. Time has taught us that even the patients who are persistent and who take their Botox injections regularly, the Botox will have a cumulative effect. And by time, the length between injections widens, and even the dose of the injection required to produce the same effect decreases. And this is because of remodeling of the tissues. When you change the tissue positions to the new wrinkle-less position and keep it there, it's more difficult, even with return of the muscle tone because of the skin remodeling and the subcutaneous tissue remodeling, to return to the same old effect with wrinkling. So we all know that Botox has a cumulative effect. With baby Botox, we give the first initial dose a full dose, okay? The same as the regular protocol of injecting Botox. But we ask the patients to come back after 6 weeks up to 8 weeks. Wrinkles have not gone back yet, but we will give him a baby dose of the Botox. We'll give him 25 to 30% of the initial dose. And by repeating this, we will actually keep the patient wrinkle-free all the time. And this is a simple graph comparing the red, which is the classic protocol of injecting Botox, where the wrinkles are high. You give the full dose of Botox, patient remains wrinkle-free for some time, the wrinkle starts to come back again, and when they come back, the patient comes for the next injection, and so on. With the baby Botox protocol, you give the initial dose, the patient, the wrinkles disappear, he's wrinkle-free, and before starting for the wrinkles to come back, he comes and gets a smaller or the baby dose. It's like vaccination and booster doses, okay? And this way, you are changing this up and down regimen into an almost flat regimen. This protocol has started with celebrities, with TV presenters, even with politicians who appear in public every day and who don't want to look good for a couple of months and then have wrinkles and then look good again for another, and so on. But what we have been doing in the last 2 or 3 years is that this is becoming the standard of injecting Botox. And we are actually achieving several advantages. Generally speaking, we're using less amount of Botox. So we definitely have less amount of complication, less incidence of complication. And actually with the small baby doses, we don't see any more doses occurring after Botox or lower lid weakness or dryness, because for every injection, the dose is about quarter of the initial injection. The second advantage actually is that the cost is reduced over time. Not only this, but even the bulk of the dose of the cost has moved from being the cost of the material going to pharmaceutical companies to the cost of the injections going to the surgeon. So it has a major financial advantage for people who are injecting. Even if patients are paying the same, but this amount is mostly directed to the surgeon rather than to pharmaceutical companies. Actually, the third advantage is that remodeling is more pronounced and more evidence with this small doses. You are not allowing the tissues and the muscles to ever return to the wrinkle period. They will always be in a wrinkleless shape. So you are making it much easier and much faster for remodeling to occur. And as I said, it eliminates definitely any possibility of frozen look or ptosis or ectropia. Thank you so much.
A very beautiful presentation. I think this is really a very nice technique, as mentioned by you. It's very good, especially who are in the acting profession, especially the celebrities, and also for the politician who needs to also want some other expression. Beautiful presentation.
Any questions from the audience, since we have some time for questions?
Or we can keep everything in the last.
Adit, we'll keep
Yes,
the
Dr.
panel
Mukesh.
discussion at the end. We'll keep the panel discussion.
Okay. Dr. Mukesh can have one question till we set up.
So I have a question, sir. Like for cosmetic, pure cosmetic reason, I can understand the effect of cumulative doses and getting it multiplied. But for functional also, like, are you following the same regime? Like,
Functional
may not be.
Functional is different,
Yeah.
okay? You have to measure and to test the function, so it's a bit different.
Okay, but for cosmetic, yes.
For cosmetic.
It is understandable.
And now I invite upon Dr. Kasturi Bhattacharjee, who will be speaking to us about application of biofillers and threads in aesthetics.
Thank you, Chairperson Dr. Adit.
and all the dignitaries here. So thank you very much. I'll be speaking on biofillers, which includes both the PRP and the PRF. Basically the PRF, because we all know that PRP is basically the first generation biofiller, and it is a PRF which is a second generation biofiller because it contains the platelets, the leukocytes, and these being embedded in the fibrin meshwork, having some amount of growth factors, and today it is being extensively used for multiple therapeutic and also the functional indication. So basically this biofiller serves as a simple, non-toxic, biocompatible and economical alternative which bears the potential for steady local release of the growth factors, making it a holy grail for the future medical and the pharmaceutical research. This PRF is basically, as I have already mentioned, is a second generation biomaterial containing different types of growth factor like the platelet-derived growth factor, the fibroblast growth factor, the transforming, the VEGF. Then we have the epithelial growth factor, the IGF, and also the mesenchymal stem cell. And these growth factors, along with the fibroblasts and the leukocytes, they localizes and enhances the tissue regeneration by entrapping and causing a sustained release of the mesenchymal stem cell. So we get it both in the liquid and also in the solid form. Like this is what you can see, and this is how we make it. We take the blood from the antecubital vein, and then once you take the blood, you need to centrifuge it. Depending upon the centrifugation, you can either have a liquid PRF or a solid PRF, and then you need to take out, in case of liquid PRF, the initial 1.5 to 2 mm we consider as PPP, that is the platelet poor plasma that you discard in, and the next of the liquid PRF you can use for multiple indication. One of a very good indication, especially for a facial rejuvenation, like this is a patient where you can see she had all the vascular malformation, and these are not very good pictures. You can see some amount of cases. I like showing this patient who came to me for a low flow AV malformation, where we treated with the bleomycin injection, and this is after the 3 cycles of bleomycin, and then you see a post-PRF microneedling, and not only the eyelid, the whole of the face, we do a regular microneedling, and you can see some changes. I'll be showing you these are the pictures, and I feel that this PRF really gives some textural changes also, as you can see here before and after the procedure, not only on the lid, but also if you really look carefully, you can see some amount of improvement also in the skin texture. We use it now many for my aesthetic indication. I mix a liquid PRF with hyaluronic acid in a 50:50. And recently what we have started doing, we are also trying to have the PRF in a semi-solid form along with the use of centrifugation and refrigeration, where you can use it also as a biofiller. So these are some of the patients you may not be seeing very clearly out here, but actually when you see the patient, you definitely see some amount of textural changes with the liquid PRF. But what about the solid PRF? The solid PRF, it comes as a fibrin membrane, and then you need to remove the membrane, and along with it, you have some amount of the RBC. You need to discard the RBC and the liquid part of it. So this is how we take the solid membrane, and this is how it comes out. See, it should be in a very sterile environment. And this membrane, now I use it for multiple indication, and it has replaced so many other tissue material that we use. I use it for my socket surgery, sometimes even for my thyroid patient, sometimes also for my fracture repair. So this is one of the aesthetic indication, and it really works very well for the scar revision, especially those resistant type of scar revision. If you use a microneedling along with this solid PRF, and you know the growth factors are trying to be pushed inside, and you see quite a good picture. So this is what you see. This is how we take it up. Try to be in a sterile environment. And then once you take it, you need to squeeze out the plasma, and also you need to remove this RBC from it, and then it can be used for different indication, whether it is for the functional or for the aesthetic indication. Like this is one of my scar patient, 1 week post-injection, and you can see at 3 weeks, comparable, a better improvement in the texture, and also the vascularity has gone down, and much of the lesion is flattened. So this is one of the patients. She was very conscious about this deep bad scar that she has been having. the whole of the tissue got stuck. She had taken filler also multiple times elsewhere. Then she wants a permanent solution. So I decided to do a surgery for her along with the use of the solid PRF that I'll be showing. So what I have done, I had removed the whole of the scar. As you can see, there's a very little amount of skin that has been removed. Then as I was removing the scar, I was trying to take some of the soothe, and this soothe will be used to form the base of this, the depressed zone, and this is the soothe that has been pulled, and this is following the base of the depressed zone, and over here I'll be putting a PRF, and this is a solid PRF that will be placed here, and this is what you can see, the soothe base, and this is a PRF, and you can see the fibrin meshwork. If you look very clearly, I have magnified it, you can see this how the fibrin meshwork looks like, and then this will be placed above here, and then this can be either glued or it can be sutured, as you can see here, and this are the patient's picture. This is pre, this is post-operative. You can see this is just 5 days, and this is approximately 10 to 12 days. So this is how it comes, the solid PRF. You need to remove the RBC. And today it has become one of the major indications for socket reconstruction, especially if you look to the Krishnaji's classification of sockets, especially the grade 3, 4, 5. So this really helps in some amount of better, post-operative recovery, as you can see in this is a patient. So this is the patient following the socket reconstruction. This is a PRF. This is 6 weeks, you can see. And this gentleman, the advantage is that the socket heals up so well, not only the healing, we can find a better epithelialization in the early phase of the post-surgical period, and also you can put a better prosthesis, and the chances of reconstruction, recontracture is much less. So this is a patient, if we look to here, a PRF veneer has been given above the DFG, and then if you look here, this is the early socket reconstruction where you have a PRF veneer over the DFG, and this is a pre and 1 month post-op with the prosthesis. So this is how it looks like. Say this is how once we do a dermis fed graft, once we remove the epidermis and we take the dermis, and what we do, we just put it as a layer over the dermis, and then in one of a study, what we have found, it not only helps in the early epithelialization, but also it decreases the post-operative pain. And when I have gone to the literature, there are reports where people are using this PRF to decrease the early post-operative pain, where they found that the use of PRF that leads to much lesser pain in any of this invasive surgery as compared to those without a PRF. So once you form the socket very well with a DFG, then you can use this as a glue, and then you can put the PRF above this, and you find that the healing is much better, and the chances of recontracture is much less, because we all know that these are the sources of the growth factors. So advantage of PRF are many, but most important, it can be used as a wound healing booster. And a little bit about the thread that I'll be sharing with you, but the most important that it is autologous, no risk of immunologic reaction. So the thread we all know is a minimally office procedure. I really love doing thread because of multiple indication. It can be a mono thread, twin thread, it can be a multi-10 thread together. One of the advantage of the thread for the ophthalmologists, it can be used for periocular rejuvenation, especially for eyebrow lifts, those patients who do not want an endoscopic brow lift or external browplasty. So this is a cork thread. I think I can take 4 minutes extra. Shilpa is not there. Can I?
Yes.
Just I'll be. Okay, so this is what 2 minutes done. Okay, so this is what I like to share some of my experience. Like you can see a really good lift before and after the thread procedure, and I feel the cork thread, and now I have switched from cork thread to PLLA thread. So PLLA thread is a real good option because I feel that with PLLA, whether you go for facelift or whether you go for brow lift, it really stays for much longer time. And this is how we These are how we place the cork thread, that you can see this is the patient pre and this is the post-operative. And nowadays you also get threads, especially for this periocular wrinkles. Those patients, the static wrinkle, even if we Botox it, whether we use a full dose of baby Botox, but you cannot remove this static lines. So these are the patient who really does very well with this very mono thread, and this really works for the static. One only thing you need to repeat after every 6 weeks. As you can see here, this lady she is in one of a very high post in my place, and you can see that she comes for her this regular usage. Another use is some amount of collagen synthesis. So these are the threads which also helps in the collagen synthesis, which are the twin thread, the PDO twin thread, which not only gives, it may not give an instant facelift, but with the synthesis of collagen, and when you get the more amount of collagen, you'll see that post-operative, the post-thread injection, it gives a much better facial appearance, especially as you can see here. So this, I'll just show a little bit about the PLLA thread. The PLLA thread is transparent. The advantage of the PLLA thread is much permanent, and you should use the fishbone. Like this fishbone advantage is that it has a blunt tip, and as you push it through the tissue layers, it opens up, and once it opens up, it gets stuck, and it really gives a very good lift. So this is how we use the PLL thread, and the PLL thread is basically for your facelift, as you can see here. But lastly, I like to conclude by showing this lady, where initially she comes to me for all her thread. She basically has a thinner face, and we all know that nowadays we do not prefer so much of filler in the face because it really bloats up the face. And I feel that to have a better collagen synthesis or a better facelift, I prefer thread much more than the hyaluronic acid filler. So this is she who usually comes to me for a regular PDO thread, but now what she prefers is the PLLA thread, because even she feels that the PLLA thread is much better. It is not moving. So this is now what I'm shifting the same patient with a different PLLA thread. This is how it comes in. It is much thicker, and also it is, much better. That is what I feel. And this is some of a patient. And with this, I conclude. Thank you very much for patient hearing.
Thank you, Dr. Kasturi, for covering such a diverse topic in such quick time. This talk by her certainly opens up a Pandora's box of the application of PRP and PRF for multiple uses in orbital surgery as well. It has been long used by the other specialties of medicine, like knee surgeons, shoulder surgeons use it intra-articularly for healing properties of PRP. So in the meanwhile, if we have any questions for Dr. Kasturi, we can just take them after a couple of talks. I would like to call upon Dr. Akshay Nair now, who is a very dear friend and also a very prolific oculoplastic surgeon. He heads the oculoplastic services at the Agarwal group of eye hospitals, Mumbai, and the R.J. Sankara Eye Hospital. Who better to talk on blepharoplasty than Akshay, who also runs a successful eye mask course in Mumbai on near live models, which I have been a part of as well. So he's going to enlighten us upon how to rejuvenate the lower eyelid in the next 8 minutes.
Thank you, Adit, for that introduction, and thank you to the scientific committee team for the invitation for this very innovative subspecialty day. So I'll be talking on lower lid rejuvenation and go over these headings. So we're looking at assessment of the lower lid in terms of how we can rejuvenate it. We'll be going over transconjunctival blepharoplasty, the indications assessment, transcutaneous blepharoplasty, complications of these blepharoplasties related procedures, some adjunct procedures, and briefly touch upon tear trough filler. I understand that's also a topic that's being covered by subsequent speakers. So when we come to assessment, the whole aim of the assessment is to know who is a good candidate for a lower lid blepharoplasty and who is not. And once you've isolated and decided, yes, we can do a blepharoplasty, we need to figure out what is the ideal route for the surgery. So when we look at lower lid, the things that can be corrected are excess skin, excess fat prolapse, that is the orbital and the lid fat pads that has come out. What cannot be corrected with a blepharoplasty is malar mounds or fluid on the lower lid. We also need to be very careful and make sure that it's not a thyroid eye disease related scenario that we are looking at. And then we can conclude what is the best form of surgery for this patient. So typically, how do you differentiate between fat and fluid, and also how do you look for excess skin, is when you look for the patient here, and you can see that there's lower lid fat prolapse. This is a relatively young patient. You ask them to look up. Now, when the patient looks up, the superior rectus levator contract, the eyeball moves up, and the antagonist muscle, which is the inferior rectus, and the orbital, the lower lid retractors relax, thus allowing the fat pads to prolapse even more. So if it is true fat pads, the appearance worsens on up gaze. Whereas if it is not fat, it would not worsen on upgaze. And now when you look down, the lower lid retractor, the eyelid, and the inferior rectus contract, pushing back the fat in position, and you see that the fat prolapse is not as bad now. Compare that to someone who's older. You can see that there's a little bit of fluid as well as excess skin. It worsens in upgaze, but it persists in lower gaze, in down gaze. So this is a patient whom you may want to be a little cautious about. You can address the skin laxity. And how do you know that? Look at the position of the limbus in the middle photo. The lower limbus, you know that there is a lower lid, a little inferior scleral shows that the descent of the lid has happened. There is lid laxity, and that also needs to be addressed. Do not miss out on ptosis. Do not miss out on malar mounds and fluid around the eye bags. Make sure that you're not operating active thyroid eye disease at this point. I love this paper by Dr. Milind Nayak, where he's explained the hills and valleys, a brief concept that I want to go over. The first, in that picture, the top right photo, the first hill that you see is the O, that is the orbicularis, followed by the first valley. The next hill that you see is the fat, or the fat bag that happens, that is prolapsed. And below that is the next valley, which is the tear trough hollow. Subsequent to that is the cheek or the cheek fat pad. So it's the orbicularis, and then the demarcation, then the fat pads, and then the tear trough hollow. And what we need is one smooth lid cheek junction, which we'll use, and using that as a guideline, we can assess which patient needs whom, which surgery. So now here, the top left photo here, you can see that the patient has a prominent orbicularis, there is a clear demarcation, and there is fat prolapse. The tear trough is not that prominent. So here, by removing the orbital fat, the lower lid fat pads, we may be able to get a good result. And again, you can see on upgaze, the fat pads worsen, which means it confirms it is fat. So a transconjunctival blepharoplasty with fat excision is adequate to address this condition. Now here, in the next photo, here you can see the fat pads aren't that prominent. If at all, the tear trough hollow is what is more prominent, and therefore, in this case, I'd rather use a filler to smoothen that out and create a smooth lid cheek junction. So a transconjunctival blepharoplasty is a fairly simple procedure. Here, I'll go over both fat excision and fat transposition. I use an infraorbital block. Let's see, yeah. An incision is made about 4 mm below the lower lid, the tarsus, and once that is done, you can directly have access to the lower lid fat pads. There is a GRED maneuver, which is described by Dr. Guy Massey, which is globe retropulsion. When you push the eyelid down, close the upper eyelid and push the globe down, the fat bulges out, and that helps you identify the fat pads. One good practice is to inject local anesthetic into the fat pad and cut the vessel, and also, especially at the end of it, cauterize and cut, because you don't want a bleeder retracting in. So you can see that the patient is awake and can move their eyes. You can use a lid protector to cover it. The fat literally needs to be teased out, and then you may give an incision and pull it out. So a transconjunctival blepharoplasty can give you very reproducible results. But there are some cases where you may not want to do a fat excision. Instead, you may want to do a fat transposition. And those are patients who have hollow cheeks, so prominent tear trough deformity or a hollow, and there is a gap in the cheek fat pad. So you want to take the fat that is from the eyelid pads and transpose it over the cheek, over the tear trough hollow, so that instead of using a filler to mask the tear trough, you're using fat to go there. So this is a patient who's undergone just fat excision because the tear trough hollow is not that prominent. Whereas in this patient, you can see there is a big fat pad, and it appears like it's fluid, but it's not. So here was a patient in whom we took the fat pads, trimmed it out a little, and subperiosteally transposed it over the tear trough hollow. And you can get a very smooth lid cheek junction in this case. So how do you do that? Through a transconjunctival incision, identify the fat pad. That's the inverse shoe shine, medial fat pad and the middle fat pad, and that's the inferior oblique muscle in between. So once you've done this, you also need to identify the tear trough, the periosteum over the tear trough, which is the anterior lacrimal crest, but medially, more laterally. Pass a suture here. I'm using a Prolene through the skin subperiosteally, engage both the medial and the middle fat pads, and then pass that back again subperiosteally through out of the skin and then through a bolster which you can tie off. So you can see the fat pads now going over the tear trough hollow and coming out. So you are volumizing the tear trough hollow and also at the same time addressing the fat that is bulged out. Transcutaneous blepharoplasty has limited uses. We use it primarily in patients who have a lot of excess skin and fat prolapse. My only indication here is for excess, is to know how much skin needs to be removed. So now when I'm pinching the skin, look how the lower lid margin moves down. That much skin is too much. Now, this much skin, the minimum amount of skin that you can pinch without altering the position of the lower lid, ideally in a sitting up position, is the amount of skin that you want to remove. I think as orbital surgeons, a transcutaneous blepharoplasty is fairly simple. You identify the septum, open it up, I look at the fat pads, and again, you can transpose if you have to transpose over here. You can get good results, and also you can always combine it with an upper and a lower lid to get a quad bleph to get good results. I have one slide on complications, which I'll go over before finishing. Subciliary scars, especially in the Indian population, heal poorly, so you want to be a little careful and close meticulously in layers. Prefer cold steel over radiofrequency cautery, especially in Indian patients. Meticulous closure is good. If you excise too much skin or there is a retraction, you can use adjuvants like 5-FU steroids intralesionally or over the scar as early as you can. Don't delay a corrective surgery or corrective measures, because at the end of the day, you do not want the patient to have functional issues at the cost of an aesthetic surgery. So I won't be talking on tear trough filler because that's being covered later on in the talk. I think I have exceeded my time, so I'm good. If there are any questions, we can answer that at the end of the session.
Thank you, Dr. Akshay. That was a great presentation. So, Dr. Isam, you have a huge experience on the bleph. Would you like to share your experience on lower lid blepharoplasty?
This was an excellent presentation about the different techniques and what we can do, whether we remove the fat, we excise the skin, we transpose the fat. The whole issue is that it should be a customized procedure. You should plan ahead, sit with the patient, take your measurements and draw, and there is no two similar patients. So for everyone, it must be customized. You don't need to have your own technique. You have to fit the different techniques to each patient separately. I think this is the hallmark of upper and lower blepharoplasty.
Thank you very much. Now we have Dr. Adit Gupta. He's the director of Mumbai Eye Plastic Hospital, along with his partner, Dr. Prerna. So he's doing tremendous work both on plasty and functional oculoplasty. So over to you, Dr. Adit, who will be covering on cosmetic eyelid surgery complications.
A very good morning, everyone. All that glitters is not always gold. After seeing such wonderful results of blepharoplasty shown by Akshay, I'm going to turn towards the dark side of blepharoplasty. As the number of procedures done overall as well as in India increase, so are the complications going to increase. As we see, blepharoplasty along with eyebrow lift is becoming one of the most commonly performed plastic surgery procedure all over the world and now as well in India. So why do complications happen? Complications could be surgeon-related or they could be patient-related. Now, surgeon-related complications are something that we should be wary about. Patient-related complications are not in our hand, but their treatment is. Now, surgeon-related complications mostly are because of poor understanding of anatomy, lesser exposure to this subspecialty during training, or sometimes because of faulty technique. Eyelid is a very intricate structure. It protects one of the most stable and the vital sense, that is vision, and even small mistakes can lead to disastrous sequelae, and millimeters matter. If we follow this complete checklist before performing a blepharoplasty and customize, we don't end up with untoward outcomes. These are some of the commonest complications which occur with blepharoplasty and the not so common ones which are seen here. And I'm going to take you through some of them via certain pictorial depictions and case-based scenarios. When I started performing blepharoplasties, I was very excited. I used to be very aggressive while removing the fat. I would get good results in some cases, as seen here, very good transition of the tear trough as well as the lower eyelid. But many a times I would be left with a hollow patient. Sometimes the patient would be happy, but sometimes they won't be. Unveiling the tear trough can lead to pigmentation and also a very hollow appearing eye, which is sometimes not preferred by many patients. So in such cases, as Akshay has already pointed out, you should perform a fat preserving blepharoplasty where you can either do a transposition or a fat transfer, which could be native fat or it could be from somewhere else in the body. Now this is one of the commonest, I would say not a complication, but an after effect of a blepharoplasty when you're in your beginning phase of your career. You would see that the fat has been removed well, but there'll be a persistent lateral fat pocket which has not been addressed. Now this is very common because this is the Eilers fat pocket which lies between the crus of the lateral canthal tendon, and we tend to forget this or excise it because usually we approach the lateral fat pocket the last, and it is a little deeper in the orbit. It happens very commonly, especially in males, because the lateral canthus can also be a little tight. We always thought that orbital fat is two-dimensional when we begin, but actually it is three-dimensional, and the lateral fat pocket after the medial fat pocket is one of the deeper pockets which should be delved into deeply. A not so uncommon complication of blepharoplasty, especially the lower eyelid when the skin is involved, is eyelid retraction. This we see very commonly when a general plastic surgeon does this surgery. This is a middle-aged male who has multiple orbicularis laxity. You can see malar festoons as well as a retracted lower eyelid after a transcutaneous blepharoplasty and a lateral canthal dystopia as well. Now these patients need to be dealt with carefully. They mostly, the physiology here is either excessive removal of skin or a pre-existing orbicularis laxity or weakness and gravitational tissue descent. These patients need to be dealt with by placing a spacer graft along with lifting the lateral canthal tendon and additionally performing a SOOF lift. They undergo, we can get good outcomes, but always the eye shape always appears changed even after performing corrective surgeries. A forced upward traction test is very important to do in these patients to determine if there is any tether, because then you need to address the posterior and the middle lamella as well. Now, when we address tether, there are two phases, the initial phase and the rehabilitation phase. In the initial phase, usually you should not be touching the patient. You should try all methods of scar modulation, which could range from filler injection to a simple tarsorrhaphy, which can be very effective in such patients if done at the right time, or filler injections along with steroids or 5-FU injections. Now this is a complication which needs to be dealt with more carefully. I saw this patient around 6 months ago. She had an eyelid malposition. You can see a very frank ectropion in the left side, an early ectropion on the right along with eyelid retraction. The frank ectropion on the left was causing exposure along with dystopia of the lateral canthus. You can also see a hypertrophic scar here at the lateral canthus where the plastic surgeon has tried hitching up the SOOF. Now these patients need to be dealt with very carefully. They need a lot of psychological counseling as well because they have gone through a disastrous result of a blepharoplasty. So to buy time, I usually perform a hyaluronic acid filler. It also acts as a spacer, which is a temporary spacer, also causes biomodulation and buys us time for 3 to 6 months till we perform a definitive procedure. It is usually done in the orbicularis plane, so there will be a little bit of fullness seen post-procedure, but that is fine. That is the trick to buy time. Sometimes eyelid malpositions can lead to entropion as well. So in this young lady, a transconjunctival blepharoplasty was attempted by a plastic surgeon, but because of aggressive cauterization and improper planes, you can see that the eyelid has rotated inside along with retraction. You can see the eyelashes are rubbing on the cornea, and this needs urgent surgery because it can lead to exposure as well as infective keratopathy. In such cases, you need to address the posterior as well as the middle lamella because this happens mostly because of volume collapse. So you need to add a spacer graft between the tarsus and the inferior phalangeal conjunctiva to stent the eyelid up. So in this case, a canthotomy along with cantholysis was done. All the cicatrix was released. The inferior oblique muscle was also present and entrapped within the scar tissue, which was also released. And a fat strip graft or a dermal strip graft can be used as a stent graft in these patients, and you get very good outcomes. There is a little bit of bulkiness in the lower eyelid, but that comes at the cost of corrective surgery. This is one scenario which we encounter very commonly in young patients who undergo blepharoplasty, especially males, post-inflammatory hyperpigmentation. Even I don't know what to do with this. This is a very tricky scenario. Sometimes antioxidants and certain times even pigment lasers with the dermatologist help in these cases. But usually males I have seen tend to develop this hyperpigmentation very often. Some may have mild, some may have moderate, but time is our only friend in these cases, and usually 3 to 6 months down the line, they tend to do better. Eyelid fold asymmetry is very commonly seen in upper eyelid blepharoplasties. This was a Northeast Asian patient whom we performed a blepharoplasty for. The first post-operative day, everything looks good, but after a month or so, you can see that the right eyelid fold is droopier as compared to the left, a little bit of hollowing here, which can explain the asymmetry as well. These need corrective surgeries where you need to do an eyelid fold revision, which can give good outcomes and a symmetrical tarsal platform as seen here. There are scar-related complications which all of us know how to manage. Usually they need time and scar-modulating agents. Silicone gels as well as scar-modulating gels work well in these patients. But these happen more so in patients with oriental skin profile because the dermis is thicker, so the reaction is more. And sometimes in repeat cases, these scar-related complications are seen more. The most dreaded complication of blepharoplasty is obviously a hematoma. This patient of mine developed a subconjunctival hemorrhage, which could also be because of seeping of blood from the transconjunctival incision. So you should be very careful about any bleeders left during the end of the surgery. But what we are more worried about here is the vision. So you need to do a thorough visual evaluation, and the patient should be given your contact number in case the eye turns red or is very painful. All of us don't want to see this complication. This is a picture taken from a textbook. Luckily, I had not encountered this in my life. But hemorrhage and blindness is one of the rarest complications, and we need to keep our radars on for this. If at all it does happen, then you have to perform an emergency cantholysis canthotomy and evacuate the wound. Meticulous hemostasis, preoperative stoppage of blood thinners helps in preventing this complication. So to conclude, the margin for error is very small in eyelid cosmetic surgeries, and majority of the complications can be dealt with if managed conservatively initially and then with a corrective surgery by an oculoplastic surgeon. Scar modulation and fillers should be used to our benefit in the initial healing phase, and counseling and psychological hand-holding is of utmost importance in rehabilitation. And you need to identify red flags or prior problem patients, especially a patient with a negative vector, a history of prior blepharoplasty, an unhappy patient. And last but not the least, I like to say that you should be very careful about this subset of patients with body dysmorphic disorders. They have a typical history of undergoing multiple procedures and wanting even more to correct the previous deficits. Thank you.
Thank you, Dr. Adit. That was an extensive and a very well presentation. And it's very rightly you have mentioned, I feel that especially in India, one of the toughest blepharoplasty is when you do a upper lid blepharoplasty for an Indian Asian eyelid, because they want a bigger, higher lid crease, and also the rest of their orientation is like of any of the Asian eyelids. So those type of blepharoplasties are very difficult because asymmetry is very common, or sometimes you find that the lid crease may not stay for 3 to 5 years as we do in the other types of blepharoplasty. And Adit has also very rightly mentioned that when we do a low blepharoplasty, we should always remember the fat is not two-dimensional, it is three-dimensional. The central is superficial, the medial is deep, and the lateral is deeper. And what he has mentioned about the isthmus, the lateral fat pad, many a times I get so many referrals because people, they do blepharoplasty, but they do not, deal with their lateral fat pad, and you find the bulge post-blepharoplasty. So it is very essential that a clear understanding of the anatomy should be done very well before you take up such surgery. So I think we'll take all the question and answers after this session. We have the last case presentation by Dr. Sonali.
How many of the audience present here perform Botox injections or fillers or even blepharoplasty surgeries? Can we have a show of hands?
I think everyone nowadays.
Yes.
In India, cosmetic
so that is a
surgery has
very
become
heartening
very
thing.
common. And I feel all the oculoplasty surgeons today doing both cosmetic, functional, everything, oncology, everything has become like, it has become a huge load for all the oculoplasty specialties.
Ma'am, I would like to add from Adit's talk here. We all know that, an eye surgeon or an oculoplastic surgeon understands the ocular anatomy better. So we have seen this, you know, the plastic surgeons doing, and most of the time they'll end up with an antilamellar retraction, lower eyelid retraction, or an entropion. So I think that message should go very, very clear. Despite this, you know, most of the patients reaches. It's just that the patient doesn't know where to go, approach, and which surgeon to approach for blepharoplasty. So the message is so very clear that in and around the eye, these surgeries has to be done by an oculoplastic surgeon.
I think 5-10 more years, and we are just 5 years behind the West. We are accelerating towards that goal.
Actually, in India, still today, the guideline is not there. The face belongs to whom? Whether it belongs to a plastic surgeon, whether it belongs to the eye surgeons, or the maxillofacial surgeon, or ENT surgeon. NMC has given a recognition to the MDS, like the face belongs to the MDS. So now we should also try that. We should make NMC realize that face actually belongs to the eye surgeon, because the main modulus of all the muscle, it is in the upper part of the face.
Totally agree, ma'am.
Pardon?
Yes. Yes. Dermatologists.
Yeah,
are-
dermatologists, but they are not doing the surgery.
No, no, they are doing some.
Now they are doing the surgeries.
yeah.
Dermatologists, blepharoplasty.
And Dr. Assam, what my experience in Middle East, so there are surgeons who just call it as eyelid trimming. They don't even call it as, right, in Egypt and Middle East. There are so many people, they don't correct the ptosis, nothing. They just tell it's eyelid skin trimming. It's called not even blepharoplasty, and it's so common, yeah.
Actually, most of non-oculoplastic done procedures are just removing strip of the skin and resuturing back.
Over to you, Dr. Sonali.
Good morning, everyone, the esteemed faculty and all the seniors. I'll be presenting a non-surgical way of rejuvenating the sunken superior sulcus with hyaluronic acid fillers. So, as we can see on the right side, we have a very young Asian woman, and on the left we see an older Asian woman, both beautiful in their own ways. But there are differences between the two. In the upper face, we see the forehead wrinkles in the older woman with a deep superior sulcus, excessive eyelid drooping, and mid-face ptosis, and lower face sagging. So the pathogenesis of sunken superior sulcus is multifactorial, with disproportion between a prominent orbital bony framework and underdeveloped soft tissues, trauma, and excessive fat removal after blepharoplasty with senile changes. The senile changes are the commonest one, with signs showing hollowing of a volume depleted sunken orbit, loss of eyelid crease with deflation of the upper eyelid due to soft tissue changes, and the bony changes when there's resorption of the bony rim leading to a skeletonized orbit look. So the main cause is volume depletion. So how do we go about treating it? There are surgical and non-surgical options, with non-surgical ones being preferred by the patients and by the doctors as well, as they're easy to perform and OPD-based procedures. Now, until recently, the surgical structural fat injection was done, but even though being a gold standard procedure, it is an invasive procedure with associated fairly significant morbidities like visible lumpiness, swelling, bruising, and poor acceptance by the patients. So, rejuvenation of the deep superior sulcus in the eyelid with a non-surgical volume rejuvenation with hyaluronic acid filler is an effective way of a non-surgical therapy. So, the technique includes, So, this animation shows the use of a cannula. First, we clean the face, the area where we are supposed to inject. As we can see, we pierce it with a needle, and then there is a placement of the hyaluronic acid fillers, which smoothens the skin and evens the overall surface. So, as you see over here, on the right side, we see a 50-year-old female who came with an A-frame deformity of the deep superior sulcus. And post the filler injection, as you can see, there is a fullness and an overall even surface. So the technique here we see is after marking of the desired area of the superior orbit, there is an initial entry tract is created laterally near the lateral orbital rim with a 24 gauge needle. And as you see, the use of the cannula is safer in avoiding any of the injury to any important structures. And while we are doing it,
Yeah, go to the next slide, I think.
Yeah, okay. So, the results of the superior sulcus deformity will be depending upon the grades of the superior sulcus. You can grade it with grade 1 being 0.5 centimeters or less, and grade 2 being 0.5 to 1, grade 3 being 1 centimeter or more deeper, and grade 4 will be a sunken depth of more than 1 centimeters with blepharotosis. Now, as you see here, we see a 55-year-old female with a pre-dermal fat injection. As you see how deep the superior sulcus is, and post the filler injection, there is a fullness and an overall evening of the surface with a very good lid crease. So, these are the prominent changes that you see immediately. Another case of a 60-year-old female of the Northeast Asian origin with hollowing around the eyes, tired facial appearance, saggy appearance around the eyelids, the typical aging changes with the A-face deformity. Again, we are going ahead with the cannula and molding the filler as we do it, because it's extremely important to avoid the lumpy look, and we always inject while coming out so that we prevent any damage to any important structure. So this is immediately post the filler injection. You see the immediate change in the upper lid crease and how well it looks after a few days of downtime. This is immediately post and pre. So Frick et al. Investigated the efficacy of a lumbrical fat graft, Magnelia with a perosteal flap, Sizzy with a dermis fat graft, and a septal fat pad implantation. So all of these come with their donor site morbidity, not easily moldable because of the fat injection, the graft hypertrophy, they're not completely reversible, and there is also a risk of injection. So in our cases, usually we go ahead with an intraseptal or a retroseptal, a subdermal, or a preperosteal. But we have used the preseptal plane, which is usually the avascular plane. It is a better plane for the filler placement and helps avoid dreaded complications of intravascular injection. It creating an initial entry track followed by the use of a blunt tip cannula provides an additional advantage to prevent multiple entry points, which further increases the recovery period. And although it is a controversial thing, a retrograde and resistance-free injection is the most key feature for safe and long-lasting results. So in conclusion, a corrective procedure for the superior sulcus is possible by a non-surgical way to corresponding to each grade with a satisfactory result. And hyaluronic acid fillers, they provide a safe and versatile non-surgical method for rejuvenation of the sunken superior sulcus. And reversibility is always the key, which is why patients are very happy with the hyaluronic acid fillers. So, thank you.
Thank you, Sonali, for such a crisp presentation. And this brings forth a very important message that, especially in the upper eyelid, if there is deflation, which is very commonly seen, inflation is what has to be done, not excision. So very new surgeons especially get tempted to remove that fold of skin, which can lead to further hollowing. So inflation is the key while rejuvenating the upper eyelid. And you have pointed it out really well. Especially in one case, I have seen that deflation sometimes occurs also because of detachment of the levator muscle. So sometimes even correction of that microtosis rolls the muscle outside and corrects the hollow along with a filler injection. That also might work well in such cases. Any comments from the audience? Any questions or any comments from Dr. Esam?
We can inject fat, okay, not just fillers, but so fat is an option, especially in patients because of fillers might have a bad reputation in the upper lid and with the danger of arterial occlusion. So fat injection might be more appealable to patients.
That's very correct, especially the nano fat or the micro fat.
The nano.
Especially when we initially used just a fat filler, we ended up with some lumps and bumps. So now most of us prefer the micro fat more than the nano fat, because micro fat also contains the stem cells. Any questions, or we can take up 2 questions?
My question is to you only, Dr. Kasturi. Very interesting talk, and as usual, you come out with interesting ideas every time. So it's always a pleasure listening to you. So you spoke about biofiller, and use of solid plasma block as a biofiller. But I believe in your talk, like what you stressed out primarily that it was used as a healing substrate and material which promoted the vascularization. So have you tried using it only as a filler, just for augmentation? Like in the dimple which was there, you did other things also, and then you supplemented it with the block of this plasma. So have you tried using plasma block, whether it promotes the invasion of tissue extra or how long it lasts, like any experience about that?
Yes, very recently, like I was mentioning, this by PRF, you can have as a liquid and as a solid. Now we have something called semi-solid. The liquid we use for the neocollagen synthesis, solid as a filler, and also for the healing process. But the semi-solid, the PRF, the liquid that you get it, you can centrifuge it. Sorry, you can refrigerate it. Once you, nowadays we get centrifugation machine along with the refrigerator. So moment you take out from the centrifugation machine, you put in the refrigerator, you get a semi-solid form. That can be used as the same hyaluronic acid filler, and I believe many of the dermatologists are also doing that. So we have just started the procedure, and this will be a very good alternative for Indian scenario, because hyaluronic is costly, number one, with some complications, but this also leads to collagen synthesis. So I have shown, I think, one very small clipping where we use it now as a semi-solid filler.
Okay. So we need a study, I think, wherein we can get some idea
Yes.
about the duration it remains there and how much it promotes the actual.
Yeah, mainly I think with respect to repetitiveness, how often do we need to repeat it, and how long does it last, I think.
Correct.
Yeah,
It'll
the
be
one
interesting
that
to see
I'm
that.
using it, I'm using approximately 3 to 4 months interval, because those are real bad hollows where they have a prominent tear trough and also shadowing effect, the hyperpigmentation. So I'm trying to follow up, just started with the semi-solid.
Thank you.
Yeah.
If no other questions,
Dr. Nair, I just wanted to ask.
Akshay is left. I
Akshay,
think.
you're here?
No, he's left.
He
I
just
I
left.
just, he said that he prefers a blade over radio frequency knife with cutting. So anybody can give
For
an.
the skin incision,
Yeah,
we
yeah.
all prefer blade because I feel the healing comes very good. But radio frequency is a good option. There was a publication in one of the OPRS journal where they did not find any change between the
Yeah,
blade and the radio frequency. But personally, I feel an Indian scenario where we have so much of scarring and pigmentation. So I usually also prefer giving first incision blade, and then the subcutaneous I start doing either the electrocautery or the radio frequency.
Thank you, everyone. It was a really well conducted, and all the speakers spoke really well. Now I invite upon Dr. Seema Das to take over for the next session.
Thank you, Dr. Adit, Dr. Kasturi, and Dr. Essam for a wonderful session.